Hello, everyone. Thank you so much for making the time to join our iVAMHN webinar on a range of research findings in gender-based violence and mental health across the world. It's so wonderful to have you either joining us live or watching this recording back. If you are joining live, just be aware that we are recording the session. But it's really nice to have people here with us live so that we can have some conversation as well. I just wanted to introduce myself. My name is Dr. Roxanne Koenigad. I'm a trainee psychiatrist in the UK, and I founded this network of researchers interested in gender-based violence in low middle-income countries. If you can hear a bit of background noise, there is a baby in the room with me, so apologies for that, but I'll mute myself as much as possible. And I'm so excited by the fantastic set of speakers that we have for you today. If you are joining not as a panelist or you're not speaking, I suggest if you could turn off your camera and mute yourself. I think the webinar format will mute all attendees anyway, but there is a Q&A and a chat function if you want to ask questions, and I will monitor that and field questions to the panelists. But I'm co-hosting you here with Barua Adamako Agyekum, who is based in Ghana. Barua, would you like to introduce yourself?
Oh, hi, everyone. My name is Barua Adamako Agyekum. I'm a lecturer at the University of Ghana, and I'm interested in gender-based violence and its intersections with mental health as well. I've done quite a bit of work with Roxanne, and we're still in the process of analyzing that and coming up with a paper. So nice to meet you all. I hope we're going to have a fantastic time enjoying the presentations as well as interacting. Enjoy, everyone. Bye.
Thank you so much. And yes, and I noticed someone has introduced themselves in the chat, and I would really encourage you to do that, because it's lovely to hear what other people are working on, and hopefully through this network meet people who have shared research interests and possibly explore opportunities later, if you're able to stay at the end, to think about ways that your work is complementary or possibly could collaborate in future. So I'm going to hand over to Barua, who's going to do introductions, and I will be in the background keeping an eye on the time so that we can all keep to time. I know that's very important when you're all so busy, and fielding questions as well. I might take a few screenshots and put them on Twitter just for your awareness. Message me personally if for any reason you don't want that to be visible with your name or anything. Thank you so much. I'm really looking forward to the talk.
Okay. So our very first presentation is from Dr. Ameeta Kalokhe. She's an assistant professor of global health at the Rollins School of Public Health at Emory University, and she will be discussing her work on primary prevention of intimate partner violence in India. So let's enjoy the talk. Thank you very much.
Thank you, Barua. Thank you, Roxanne, and everyone for joining us today and being part of such an important global effort on addressing violence against women and its impact on mental health. I am going to do my best to screen share. I was just telling them I managed to screw this up pretty frequently, but let's see if I can pull this up. Can you see it okay, Barua?
Yeah, that's fine. Perfect. Yep.
Thank you. Well, today I was asked to speak to some of our work in India, and just to begin with some of my motivations around this work. Also, for me, we're really seeing the impact of intimate partner violence and violence against women in my own family and my community at large, both here in the US as well as in India. And so just a quick outline today, I'll be talking about the global burden of intimate partner violence, definitions of intimate partner violence, the health impact, and then jump right into some of our own scale development work around the Indian family violence and control scale, and then more recently, the development of our intervention for primary prevention of intimate partner violence in India. So if I can just begin with the definition that the World Health Organization has provided us for intimate partner violence against women, that it's any behavior by a current or former male intimate partner within the context of marriage, cohabitation, or any other formal or informal union that causes physical, sexual, or psychological harm. And on the right, you'll see the various dimensions that comprise intimate partner violence, including physical aggression, sexual aggression, psychological abuse, controlling behavior, stalking, as well as economic abuse. And it's important to recognize these various different dimensions. Using the World Health Organization definition, the WHO conducted a study that really examined and provided us with global estimates of intimate partner violence. And through this, we understand that approximately 1 in 4, a little more than 1 in 4 women across the globe who are ever married or partnered, age 15 to 49, report lifetime experience of intimate partner violence, and 13% in the past 12 months. And so while IPV is reported greatest in low middle income countries and regions, it clearly is of pandemic capacity that it's experienced by women globally. And it starts early. That we know that, from these studies that roughly a quarter of women aged 15 to 19 report lifetime physical and sexual IPV. And while we don't yet have more recent estimates, we know that across the globe, based on reporting to helplines as well as police centers, that IPV has likely increased throughout the globe during the COVID-19 pandemic. What's important to recognize here is that these are strictly estimates for physical and sexual IPV and do not include the other dimensions of intimate partner violence that I mentioned on the previous slide. And so why is that? What about psychological abuse and control? Well, there's a lack of global consensus on standardized measures. And, this is in part due to differences in how psychological abuse and control are conceptualized and manifest across cultures, contexts, and how they're interpreted by the individuals who experience them. Also, there's considerable debate as to whether controlling behaviors are part of the spectrum of psychological violence or not. And lastly, there's debate over the thresholds that are set to really determine prevalence around severity, frequency, as well as the context in which that abuse and control happens. And so there's a really nice review by Folingstead et al. That really kind of gets at the complexities around measuring psychological abuse and control and conceptualizing that. But we know that it's important, right? That measuring and accounting for psychological abuse and control is important because it's linked to poor mental health. There was a nice systematic review that was done by Doak et al. That demonstrated that both psychological abuse as well as control were linked to depression, anxiety, and PTSD, with almost a twofold higher odds for all of those. Prior reports have demonstrated its link to other physical conditions, including chronic pain syndromes, irritable bowel syndromes, STIs inclusive of HIV, substance abuse, among other physical health conditions. And lastly, I think it's been recognized that psychological IPV is a predecessor for physical intimate partner violence. And so it's important to recognize as an early manifestation of intimate partner violence. I think across the globe, we're in agreement that it's important, and it's part of one of the United Nations SDG indicators that countries now have to report on the proportion of ever partnered women and girls age over 15 years subject to physical, sexual, or psychological violence by a current or former intimate partner in the previous 12 months. And so, valid measures of psychological abuse could really, and control, could very much enable identification of a unique population in addition to additional intervention and prevention. It could also help prioritize populations for early intervention before the onset of other forms of abuse. And for IPV intervention trials, it maybe could provide an important early outcome or early signal of efficacy. Recognizing that sometimes for us to see that same signal for physical or sexual violence may take additional time. And so now switching gears to the India context. Most recent national data, according to the Demographic Health Survey or National Family Health Survey conducted in 2019 to 2021, approximately 29% of ever married or partnered women aged 18 to 49 years report physical and or sexual intimate partner violence. And we know also in India that per police reports, as well as call line increases in calls to the crisis lines, the IPV reporting increased during the COVID pandemic as well. And there's a really nice paper that demonstrates that the number of domestic violence complaints increased proportionately with the severity of lockdown or the enforcement of lockdown during the early pandemic years. So, I think when we think about intimate partner violence or domestic violence, it's really important to think about it in the cultural context. And so for India, the Domestic Violence Act of 2005 provides really important context to where and how IPV manifests. So per the Protection of Women from Domestic Violence Act of 2005, domestic violence is conceptualized as physical, sexual, verbal, emotional, and economic abuse against a woman by a partner or family member within a shared household or joint family. And that's important considering the context in which marriages occur in India, where whether or not a woman lives in a joint family with her in-laws after marriage, the in-law family is very influential and very involved with the couple post-marriage. And so that has both protective effects, but also family members or members of the in-law family can also be common perpetrators of domestic violence. And so when we started off on this work about 10 years ago, we looked at some of the commonly used measures in India to determine whether they were accurate or effective measures of domestic violence. And here you'll see the measure that's commonly used in the DHS surveys, as well as the Indian National Family Health Survey. And what you'll find is that there's a couple of shortcomings for the India context. So first, that it really solely asks about violence that's perpetrated by the spouse. That many of the tools that were commonly used to perpetrate violence in other settings, such as knife violence or gun violence, were much less common in India. The other readily available tools may be more appropriate weapons, or more commonly used weapons of abuse. Sexual intercourse, we recognize that many in school systems pre-marriage that many women were not actually privy to sexual education or relationship education, and so as well as the sexual rights of a husband and how that's was seen very much dictated how they might respond to this question. And then we recognize that the psychological abuse questions really were limited in scope and understanding the full spectrum of psychological abuse and control that women experience in India. And so we set out to develop the Indian Family Violence and Control Scale, which, to look for a more appropriate measure of domestic violence in the India context. And so to do this, we employed a mixed method study that first involved formative work consisting of systematic review, qualitative interviews with both domestic violence experts in the community, as well as focus groups with various community members. And we used this to develop the item pool for the IFVCS, and then to do early validation work and testing of the item pool with married women in Pune, India, and then assess early psychometric properties, including internal consistency and constructability. And so this work has very much been on the backbone of Dr. Seema Sahai, who's been my mentor and co-PI now for over 10 years. And this is the National AIDS Research Institute, who's really been a key partner where she's housed, and it's one of the notable HIV institutes for medical research in India. The Department of Social and Behavioral Research that Dr. Sahai leads has really been much of the on-the-grounds work, and who've really been privy to a lot of the hearing firsthand from the participants, their experiences. And just to show you, this is Pune, India. It's located in the western state of Maharashtra. It's the second largest city in Maharashtra, and is really a cultural hub known for its theater, for its songs, for its academic presence. And so this is where a lot of this work has been conducted. And so the systematic review really allowed for us to get a sense as to how domestic violence was being discussed across various studies in the Indian context over the prior decade, and the various forms of domestic violence that these studies were reporting. And so, these form the basis for many of the items in the IFVCS pool. Here you can additionally see that each of these dots represents a study that provided a point estimate around prevalence. And you'll see that the bulk of studies were around physical abuse, much less so psychological and sexual abuse, and even fewer reported on more than 2 forms of abuse. You'll note the large spread also across the prevalence estimates provided, and some of that is wanted variance due to just differences in the samples, but additionally, only 1/3 of studies used validated domestic violence instruments, and those that were used were developed in Western contexts, including the CTSD. And so next, we embarked on qualitative interviews, key informant interviews with various members of the community who very much respond to and support survivors of domestic violence, so psychiatrists, police commissioners, domestic violence and human rights lawyers, NGO leaders, sociologists, anthropologists, etc. And then we also conducted gender concordant focus groups with community members to understand how the community was perceiving domestic violence in India. And we specifically asked about, strategies and barriers to asking about domestic violence, various forms of violence, etc. And so from this, this is just a glimpse of some of the items that we extracted from both the systematic review as well as the qualitative research that formed the ultimate 63-question item pool for the Indian Family Violence and Control Scale. And you'll see that they were mapped onto the 4 domains similar to the conflict tactics scale, psychological, physical, sexual, and control. But that each of them, demonstrates maybe some of the different ways in which domestic violence manifests within India. So, when a woman is often married, she often lives with her husband's family in a joint family setting. And so a form of psychological abuse that came out was that sometimes this, the act of being sent to her mahar or her natal family home against her will can be considered psychological abuse. Being harassed for dowry or manban, or for having a girl child or for infertility were common mentions of domestic violence. In physical abuse, you'll see that many of the commonly used tools were actually belts, stones, broomsticks, rolling pins that are more commonly available. And with control and isolation, you'll see some specific cultural manifestations related to, for example, being forced to change their physical appearance, being forced to change their diet from veg to non-veg, or perform fasting against their will. And so these are just a handful of some of the examples that came out from the item pool. But time and time again, from the interviews, we did hear that we really need to think about multiple perpetrators of abuse, not only the spouse, but also various members of the marital family. So this is just some background on the quantitative methods we used to develop and validate the scale. We used surveys with 630 married women, and this was a geographically clustered sample through 16 wards in Pune, India. Representative of Pune, 94% were Marathi speaking, 5% Hindi. The majority, by and large, were administered verbally, and we administered these surveys with 3 different scale versions in differing order, just to make sure that the order in which we actually administered the scale didn't affect responses. And so here on the left, you'll see that the demographics are very much consistent with the 2011 census of Pune for married women. So the mean age of 35, the majority being Hindu, followed by Buddhist and Muslim, a diversity of employment and income types, and 87% being arranged marriages and 42% being members of a joint family. You can see that overall for the control, psychological and physical subscales, that we had good internal consistency and acceptable internal consistency for sexual domestic violence subscale, and that constant validity when we checked associations with various demographics and pregnancy and age at first child, all of these were associated with each of the different subscales, and that we had strong concurrent validity versus the NFHS CTS2 scale as well. So our conclusions from that work was that the IFECS is culturally tailored, it has good internal consistency and constructability, but that it requires really future validation across other populations, both rural, tribal, and other regions of India also. But that we found that it might be used to inform and evaluate domestic violence prevention strategies. And over the past 5-6 years since we've published this work, we've had numerous requests for its use, but at the same time have recognized that it's very lengthy. And so we're currently working with Anita Raj and Ameeta, statistician to develop a short form that's for both the psychological and control subscales. So it'll be more easy to use for those who are interested. Okay, so now I'm going to switch gears a little bit to talk about our work around primary prevention and our development of the Gihabarari Ekatra intervention, which is a couples-based intervention for primary prevention in India. So why is primary prevention so critical? So, you know, I think first and foremost, obviously, that it's a human rights violation, that the burden of IPV in India as well as across the globe is substantial. And then also that in India, as with, you know, other resource limited settings, that secondary and tertiary IPV prevention resources are saturated. And this could include the legal system, the law enforcement system, shelters, etc. And we recognize that primary IPV prevention should really prioritize individuals of low income, although we equally recognize that it happens across people across the income sectors, but that women in the lowest wealth quintile were reporting over 2.5 times greater prevalence of past year IPV compared to the highest income quintile. And, you know, I think in India, what was unique was, you know, the ideal timing for primary IPV prevention could happen post-marriage. I think in a lot of high-income settings, or schools, IPV prevention and discussions around relationships, sexual relationships can happen in school settings and college settings. Social taboos didn't allow for this in India at the time, and you know, high dropout rates, particularly among low socioeconomic groups during schools, also didn't allow for that. And the next period between engagement and then marriage would seem natural for primary prevention, but because it's often so short and consumed by social and religious rituals, that also was not an opportune time for primary prevention. But what was an opportune time is immediately post-marriage. And what we recognize is that, you know, premarital courtship in India was still limited, that over 90% of marriages at the time were arranged, and the age of first sexual relationship was often delayed to post-marriage, so allowing for primary prevention to happen in the immediate post-marital period. So, you know, I think additionally that IPV prevention, we recognize the importance of doing this through engaging both members of the dyad, and that we thought that this needed further exploration. At the time in India to date, a lot of the work had focused on women alone, men alone, or mother-in-laws as well as daughter-in-laws together in IPV prevention. And similarly, at the time in resource limited settings globally, there was really no couples-based IPV intervention. Since then, there have been important interventions that have emerged both in Ethiopia as well as Rwanda and other settings also. But we rely a lot on couples interdependence theory, recognizing that for other health issues, for example, that the coupling, recognizing the mutual benefit of working together, seeing a shared action plan had around the health effects very much, you know, enhance their engagement and working together towards that health benefit. And so we hypothesized that by using this theory, we could do similar for intimate partner violence, that if both members of the dyad saw the benefit of a healthy relationship and perceived domestic violence as a health threat, that this could lead to transformation of motivation, that next, as they engaged in shared vision of the action plan around intimate partner violence, that this ultimately could reduce the domestic violence or intimate partner violence experienced by the couple. And so our aims were to develop and pilot a couples-based primary prevention intervention for intimate partner violence among newly married dyads residing in slums, so low-income communities in Pune, India. And this is just an overview of our overall study design. That phase 1 employed quantitative surveys to explore determinants of DV perpetration among recently married men, as well as to explore determinants of domestic violence experience among recently married women residing in Pune slums. And we used these, you know, correlates or determinants of domestic violence to ultimately inform the intervention components. Next, in phase 2, we engaged in qualitative research to really inform how should the intervention be delivered, and what should the content look like to make sure that it's engaging. And it was developed using this couples interdependence theory that I introduced, intervention mapping, and then iterative feedback from both the Community Advisory Board as well as GBV experts in the community. And then we did a small pilot to assess its acceptance, feasibility, and safety and preliminary efficacy. So before I forget, Gavarari Ekatra means to take a flight together. And so aim one again, which was to identify the correlates of IPV perpetration among newly married men and experience among newly married women, employed a 182 item survey. And we specifically are targeted newly married men and newly married women age over 18 that were residing in some communities in Pune and had been married for 3 to 15 months. And we specifically made sure for safety reasons that these were 2 separate samples of men and women, that they were not couples. And the outcomes that we assessed were past 3-month IPV experience among women and past 3-month IPV perpetration among men. And the correlates that we explored were very much informed by correlates that have been identified across the globe related to gender attitudes, sociodemographics, IPV norms and conceptualization, marital relationship quality, communication and reproductive health, sexual communication and reproductive health, conflict resolution and communication skills, stress, coping, resilience, self-esteem, as well as the male's partners, alcohol, drug use, and bedding. And ultimately, from this long list of correlates, what we found, and so I'll get to that in a second, but with the participants, you'll see here are representative of those of lower socioeconomic status residing in Pune. And the important finding from looking at the demographics was already within the first 15 months of marriage that over half reported being pregnant, and that has important implications as we think about development of our intervention, because what happens is during the 3rd trimester of pregnancy, many women in Maharashtra go back to their natal families to deliver and for postnatal care. And so this would mean that would be an interruption as in the actual intervention delivery, and so has implications for how we thought about that. I'll talk about that in a minute. But of those long list of correlates of domestic violence experience among women and perpetration among men, these are the ones that emerged in our sample. So for women who reported domestic violence experience, that experience was correlated with having a lower education of spouse, reporting that domestic violence occurring in a friend or relative may be suggestive of stronger norms around domestic violence acceptance, the conflict, poor scores of conflict negotiation skills, having family dissatisfaction with the dowry they received or manpan. Among men, correlates of domestic violence perpetration included having more conservative definitions of intimate partner violence and domestic violence, spending less time together in the relationship, feeling as if they hadn't attained what is, required to be a husband or a male partner, being jealous when their female partner spoke to men outside the family, and then reporting lower on our resilience scale. And so you'll realize that, some of these are more easily changeable correlates or determinants than others. And so those became the focus of our intervention. So phase 2 is really what I kind of consider the community consultation to inform intervention content and delivery. And so for this, we employed qualitative methods to really think about how can we ensure that this intervention, as we develop it, that it's acceptable, it's feasible, it's safe, it's sustainable, and effective for the community for whom it's intended. And so we conducted key informant interviews, again, with various members of the community who support survivors of domestic violence, as well as are engaged in preventive efforts, who we really saw as the experts around the content development. We also conducted focus groups with maritally experienced men and women to learn from their experiences of early marriage, as well as members of the in-law family. And the themes that we were looking for from this qualitative work included the content of the modules, how we could deliver it, specifically the timing, setting, interventionist characteristics, and training, so that it was acceptable, feasible, and safe, and strategies to enhance the safety, acceptance, and feasibility, and lastly, barriers and strategies for recruitment and retention. And so I think this is perhaps the most exciting part of this work is what we learned. So first and foremost, we learned from the participants that it had to be fun, it had to be something that the couples had never seen before, and it really had to be participatory and interactive. It had to be with convenience to the couples, recognizing that Thursdays and Sundays are the only days off, that those would be the days and evenings on the weekend that we would have to host the intervention. That it had to be perceived benefit not only to the couple, but the family at large. So both the in-law family as well as the child or the unborn child. So thinking about, financial benefits as well as, or perceived financial benefits and reproductive health benefits. It had to address competing interests, recognizing that this is a community of low socioeconomic status, that we had to think about financial empowerment of the couple together. Engage in-laws in the pre-consent process, recognizing that they are critical in a lot of the decision-making around consent. That while all other sessions can involve the couple together and be interactive, that we learned from the experts that the session on sexual and reproductive health very much had to occur in gender concordant groups for it to be acceptable and be very much a lecture pictorial format rather than being engaging and participatory. And then lastly, if we wanted to ensure that men were part of the conversation and participated in the interview, in the session through the end, that we could not start by addressing domestic violence, and that rather it should be that that a lot of that conversation around domestic violence needed to happen towards the end of the intervention sessions. And that when we talked about domestic violence, well, I think most everyone recognizes that women bear the disproportionate burden of domestic violence, that we needed to talk to the couple about domestic violence and being potentially bidirectional, avoid gender discussions, and again, address domestic violence last to ensure that we could get participation from the men through the end. And then lastly, address pregnancy as a barrier, recognizing that women who are pregnant in their third trimester do go back to their natal family homes, that we would lose them if during that period. So to think about that as we thought about the intervention design. In terms of safety,
Ameeta, sorry to interrupt, just to say you've spoken for 30 minutes, so you have about 5 minutes left.
Perfect, thank you so much, Roxanne. That safety really, that we needed to talk to the community around sensitization and so that people weren't talking differently about the intervention and causing undue harm, referring women to support services, and I won't go through all of these different safety implications. Additionally, through the qualitative interviews, we learned that couples very much were interested in learning about sexual communication and sexual relationship, as well as reproductive health. And so that, in addition to the components that I mentioned, became a session in and of itself. And then in terms of sustainability, that we needed to think about really using community members as the facilitators and integrating this within governmental programs. So ultimately, the Gyavarari Ekatra intervention goes as follows. It's a weekly 2-hour session delivered over 6 weeks to groups of 5 couples who have been married less than 12 months, cohabitating in a slum low-income community, who speak Marathi, and we excluded those who reported physical or sexual IPV, given that this was a primary prevention intervention, and those who are in their third trimester of pregnancy due to the various challenges to having the woman be able to participate through all sessions of the intervention. And the facilitators are 2 community educators, 1 male, 1 female. And this very much, we learned that it had to happen in community settings where the couples resided. So this included schools, halls, childcare centers within the community. So this is the intervention. It's 6 modules. The first really focuses on the couple recognizing the value of spending time together and thinking about brainstorming ways how they can better do that. And the second is I'm a champion, I can't be broken, I don't accept it. It really focuses on resilience and talking through many of the common stressors, including financial stressors, health stressors, and having the couple reflect and think about various community resources, family resources that are available to them to address those different stressors. The third really focusing on communication and conflict management. The fourth on empowerment, including financial empowerment of the couple together, and goal setting and goal planning together. The fifth on sexual communication, the sexual relationship. Again, that's the one that happens in gender concordant groups. And then lastly, a lens into domestic violence, ending with discussions around domestic violence, really trying to work with the couple to expand their definitions of what constitutes domestic violence and committing to a life free of violence. And the start is just to remind you that each of these are, very highly participatory, include games, include competitions, include role play and reflection, and that really what enables participation. This is just an example of one of the modules. These are the films that were developed based on the qualitative transcripts that really walk us through the different challenges that newly married couples face, both from a woman's perspective and her husband's perspective, and really led to a lot of discussion around both of these. And I unfortunately can't talk you through much of them right now. But just to quickly get into some of the early safety and acceptance, roughly 1/3 of those who were approached agreed to participate and were enrolled in the study. And you'll see that among those who were amenable and were enrolled in the study, that 85% of those couples completed at least 5 of 6 sessions. So really strong retention once they were enrolled. Again, this is largely representative of a group of individuals who are of low socioeconomic status in Pune. Those slight differences in the intervention control group, but this was not randomized. It was very much a pilot intervention study. But what we learned is that it was highly acceptable, that specifically they really appreciated the participatory nature of modules 3 and modules 4. They enjoyed the games, they enjoyed, the competitions, and were very engaged and were asking for more actually at the end of the 6 sessions. I think, there were small changes that we would do around the second module, which was very heavy relied on literacy, that I think we could, slightly alter, but overall it was highly accepted. We had no safety events, no reports of physical or sexual violence in either of the groups. And at 3-month follow-up, when we asked women, they reported feeling safe throughout the intervention period and denied any family conflict arising throughout the period of the intervention. No major feasibility concerns, with the exception that, these are communities, venues that are very much in heavily, that they're busy communities, and so there's often bystanders who are interested in coming in and seeing what's happening, and so we really needed to dedicate staff presence to deterring them away from the intervention sessions. But overall, high fidelity to all of the exercises, with the exception again of module 2. And while we saw no differences, actually no reports of physical or sexual violence in either group, it was a short, follow-up period, being a pilot study, and few incidents of psychological abuse, but there seemed to be a trend toward less psychological abuse in the intervention versus control part. With our next steps, acceptable, safe, and feasible, but that we really need to now explore its larger scale efficacy and its mechanism of action. So just to end now with a thank you to our big team, really to Dr. Sahaya, who again has been now a mentor and co-PI for over the last 10 years, the India team, who very much does a lot of the boots on the ground work, many of our US team who's helped with a lot of the methodology around these studies, and then our funding support, as well as the support of the Indian Council of Medical Research support in this work. So I will open it up for any questions. This is my email address in case we don't have a chance to get through all of the questions, but I will end there, and thank you everybody for listening.
Thank you so much, Ameeta. There's so much there in your presentation, incredibly interesting. No one has typed a Q&A yet, but please raise your hand if you have a question you'd like to ask live now. Sorry about my background noise. Oh, Rebecca Brambila has raised your hand. I think you're able to unmute yourself. Can you go ahead? I think I've unmuted you now.
Can you hear me now?
Yes.
Yeah, I didn't have the unmute function before. It should be working now. Thank you very much for this presentation. It was incredibly insightful and useful. Rather than on the intervention, I have a general question about IPV in India, because I've recently read of this phenomenon of husbands who get the dowry payment and then disappear after the wedding, after the marriage. And this has become increasingly hard to regulate and persecute, because sometimes they take all the money and go abroad. And India doesn't have extradition treaties with a lot of countries, meaning that it's extremely hard to persecute. And this comes at a huge psychological and emotional damage to the women, who are then, made fun of in their communities and then sometimes ostracized, and it brings a lot of shame to the family. And yeah, I was wondering if you have ever planned to look into that phenomenon as well, or if you're aware of it. And yeah, just because you were talking also about the period post, directly post marriage, if something could be done about that in that period as well. Thank you. I hope I explained myself well.
You did. Thank you, Rebecca. That's a great question. I think it did not come up in our formative work. And I think part of the reason is that this was, a lower income community where, they very much live within the community, and this foreign travel or outside travel is, we hear less so. But I will tell you, I think what did come up was oftentimes the manban, or the gifts that are given to a woman during like the marital period, that is often the control over that spending, and the control of that is within the in-law family, whether the husband or other members of the in-law family. So that very much happens, whether or not they physically run off with it, but that even if they don't physically run off with it, that control is not in her hands.
Thank you very much.
I think we'll just have two more questions. We've got Diksha. Do you want to go next?
Yeah, sure. Thank you. Hi, Ameeta. That was wonderful. Thank you for your wonderful presentation. And it was great in a way because I could relate it to our context, because I'm from Nepal and I can see some similarities in the sociodemographics and how even the contextualizing how IPV is defined, so that was great. I want to ask whether you have considered, because especially in a low-income community where we can see that domestic and family violence, or IPV, is highly prevalent, we also see that it's more prevalent among those couples who have at least one partner who is consuming alcohol or substance abusing, that kind of thing. So in my study or in my experience, I have seen that couple who have at least one partner heavily drinking, another partner will also drink, and that will lead to victimization as well as perpetration. So it's not just men who are perpetrating violence against women, but it's also that they are being victim of violence themselves. So have you found similar situation, or have you considered of measuring violence violence perpetrated against men by their spouse?
I think that's a terrific question. And in short, we have not. And I think that definitely needs to be explored. I think what I'll tell you is that you're right, that we did see high utilization of alcohol abuse among many of the men that we surveyed. But interestingly, that it didn't come out as a key correlate of domestic violence perpetration among men. But I'll tell you, as we a lot of that formative early qualitative work, we did hear that if we didn't, if in terms of intervention timing, that we had to do it earlier in the evening, because as the evening progressed, the alcohol consumption would increase. And so if we wanted to engage with a couple, we had to do it in the early evening versus the later evening night period. And so it did inform intervention delivery in that sense. I think it's a terrific question. It's whether the experience, other forms of violence that these men are experiencing very much affect their perpetration of violence. We didn't look at that, but I love that you're thinking about it.
Thank you. Thank you.
And finally, Barua, perhaps you can ask your question and then lead us into the lightning talk.
All right. Thank you, Dr. Kalokhe. That was a great presentation. You did indicate that pre-intervention community sensitization and efforts were critical. I just want to know if, find out if you could unpack that for us a little bit, and how much of a difference did that actually make?
Yeah, thank you so much for asking. I breezed through that, recognizing I was time limited. That was really, really important. And what that looked like was members of the research team who have very much worked in these communities for years in the context of HIV and knew them well, went to the communities alongside our peer educators and facilitators to start building rapport with various community members, invited in-law families to say, look, this is what we're doing, that we're going to develop this, we're implementing an intervention around healthy family relationships, not talking about domestic violence at all, but that we would give newly married couples the building blocks to develop a healthy, happy home, and not just that relationship, and allowed them to ask questions around the content, tell us what would be important again around the content, engage that discussion. I think what that allowed is later less speculation around what the intervention was about, including wrongful speculation. I think it led to a lot more support for the couples being able to participate across all 6 intervention sessions rather than being pulled out early. And I didn't mention it, but the team, the research team also had the support of different NGOs in the community, as well as police precincts in the area, because if a safety issue were to arise, that they would have that support when they would call that we were delivering an intervention. And so it was really, really important. And I'm sorry I didn't get to talk about all of that.
That's okay. Thank you very much.
Thank you, Bro. Okay, I'm going to stop share. Thanks, everybody, for listening.
Okay. Thank you very much, Dr. Kalokhe, for that really insightful presentation. Our next presenter is Dr. Diandra Daley from King's College London. She is going to be talking about interventions for women who report domestic violence in pregnancy in low and middle income countries. We are very excited for this. So you're welcome, Dr. Daley.
Thank you. Let me just try and share my screen. Bear with me. Sorry, bear with me. Just having some trouble showing my screen. 1 second. I think I've got it now. Lovely. Can you see that?
Yeah.
Yeah, brilliant. So hi everyone, thank you for having me. My name's Diandra. I'm an academic clinical fellow in general practice at King's College London, and I'm very quickly going to talk to you about a research project that I designed and completed as part of my master's in international public health back in 2019, and then I did go on to get this published as well. So why did I choose this topic? So this project that I did was actually my first sort of taste and real insight into the topic of domestic violence, particularly in the context of low and middle income countries. As I was doing my research and my master's degree, I noticed there was a lot of talk about the sort of social determinants of health and acknowledging that things like, you know, poverty and deprivation, poor sanitation are all things that will very much affect someone's health. But there was also, you know, sort of a lot of acknowledgement of domestic violence being a risk factor that does very much influence these social determinants, but there wasn't much being done in terms of addressing domestic violence and trying to sort of modify these risk factors in any way. And I did notice that a lot of the service provisions that were actually being put in place on the back of a lot of research was very much focused on physical health, and that screening and referral processes and management interventions are very much sort of routine in sort of health provisions in high income countries, but this was definitely not routine, and that's something I was quite sort of quick to pick up on. So in terms of my methods, so I did a systematic review. I looked at evidence which described the types of interventions that were being implemented and whether or not they were evaluated in terms of their effectiveness. And this was looking at interventions for women who reported domestic violence either during or after their pregnancy. I looked at both published and grey literature, and in terms of the outcomes I assessed, I looked at firstly whether there was a reduction in either the frequency or severity of domestic violence, and two, whether there were any sort of improvements in either the physical, psychological or social health outcomes for these women. And I described my findings in a sort of narrative analysis. So in terms of my results, out of about 4,000 or 4,500 studies, only 6 met my inclusion criteria. This consisted of about 894 participants. And interestingly, all these studies assessed women during pregnancy, and none of them went on to look into sort of women's experiences after childbirth. All of my studies that I found were in middle-income countries, so 2 in Kenya and 1 each in Peru, Nigeria, South Africa and India. There was quite a variety of study designs. I think only 2 were randomised controlled trials, and the majority were quite sort of weird and wonderful and less conventional study designs. Out of the 6 studies, 2 of them were conducted in secondary care health settings, so in hospital settings, and the majority were conducted in some form of primary care setting. The majority of studies recruited their women during antenatal visits, whereas 1 study incorporated sort of a specific sort of community outreach programme looking specifically at domestic violence, and the remaining study recruited women as a sort of secondary screening as part of their HIV post-test counselling. So in terms of the interventions, the majority of studies implemented some form of supportive counselling for women who experienced domestic violence during pregnancy. The remaining study designed and implemented a routine screening programme for domestic violence, and arranged supported referrals for women who were identified as experiencing domestic violence. Interestingly, only 53% of women who were identified actually consented for onward referral for further support. In terms of the effectiveness of the studies, only 2 studies evaluated the effectiveness of their interventions, but they both found that there were statistically significant decreases in the occurrence of domestic violence following their counselling interventions. And then looking at sort of other outcomes that were assessed, so there were statistically significant increases in family support following counselling, and there were also across all studies improvements in quality of life, increased use of safety behaviours, improved social support, increased access to community resources, increased use of referral services, and reduced maternal depression that was found across all studies where these interventions were in place. Overall, the quality of my evidence was actually low to moderate. I think that's mostly due to the small sample sizes across a lot of the studies, and the fact that a lot of their study designs weren't of the best quality either. So in terms of what I concluded from my research, well, it's very clear, it's very obvious that some sort of screening, referral and supportive counselling is very much likely to benefit women who are experiencing domestic violence during pregnancy. And I suppose we can assume that this would very much be the same for women who experience domestic violence after pregnancy too. But it's certainly true that much more research is needed, so much larger scale and higher quality research is needed to evidence the effectiveness of these interventions. And it's quite clear that both a combination of not only sort of improved availability of these resources, but also a sort of review process where they're continually evaluated for their effectiveness is needed to inform policy and the decision making that goes on in terms of devising sort of service provisions for maternal health care in low and middle income countries. And thank you. I just thought I'd put a screenshot here of the study in case you did want to go and read it in a bit more detail, and just a link there to the DOI as well. Thank you.
Thank you, Diandra. That was amazing timekeeping. You only spoke for 6.5 minutes, so we do have some time for some questions. Does anyone want to raise your hand or write anything in the chat? Were you surprised by how few studies met your criteria?
I really was surprised, because I think, you know, in terms of domestic violence being a thing, it's very widely acknowledged that, you know, it does exist and it's a really bad thing, and, you know, more needs to be done to address it. But are we actually really addressing it? Not really as well as we probably could be, particularly in low middle income countries. There's a big emphasis, you know, which I do understand, there's a big emphasis on addressing the physical health needs, because there are a lot of physical health needs in low middle income countries. But I think we all know very much so that you can't sort of be healthy, you know, if you're not sort of addressed holistically and treated holistically. You know, your mental health and your emotional health very much affects your physical health. So I think there's increasing understanding that you can't have one without the other. But definitely when I was doing this research, it seemed that, you know, low and middle income countries are sort of quite slow to recognise that, and there's still a lot sort of being done at the moment, but nothing's quite solidified.
Barua, would you like to ask a question?
Yes, thank you, Diandra. That was amazing. You stated that only 53% of women accepted referral for further support. Could you why? What do you think was happening? So not every paper sort of explained why uptake was low, or consent to participation was low, but where they did sort of provide reasons, it was mostly out of fear of repercussions. There was a very, very big sort of fear of causing a family breakdown and causing disputes within the family. There was a lot of feelings of shame around it. It seemed that a lot of the women who were experiencing domestic violence were in rural communities, quite small communities where everyone knew each other. So there was this big issue of stigma, essentially, and sort of exposing yourself and the family's sort of secrets. And I think a lot of that comes down to culture as well. So I think that is a huge sort of difficulty and barrier, if you like, when it comes to addressing something like domestic violence as well. And in my reading, I learned of a proverb that says that a woman's heart is the graveyard of her husband's sins. So if you have this kind of mindset, then it would be very difficult, you know. So I'm wondering how there was an increase in family support after.
So I think from what I've determined from the research, again, the research itself wasn't of the best quality, so that there's a lot of missing detail and a lot of missing gaps in, you know, why. There was still a lot of questions that I had unanswered, but what I could sort of figure out is that it essentially generated a lot of discussion within families. So actually, in turn, women found that talking to their other sort of female family members and mother-in-laws and grandparents and sisters, they actually found they had a lot of shared experiences and shared feelings about their experiences. And I think in that way, they felt a lot more supported, and in that way, it just got people talking. And in a way, it was sort of less stigmatized, or starting to be less stigmatized, just by having more conversation about it.
Yeah, great. Thank you very much.
Thank you.
We do need to move on to our next talk, but just to flag that Karen in the chat has pointed out that the HERA project might have some relevant resources for your work, Diandra, that you can have a look at. Thank you so much. I'll hand over to Bura again.
I'm sorry, my mute was still on. So thank you very much, Diandra. That was an amazing presentation. Next speaker is Dr. Abigail Hatcher from the University of North Carolina, and she will be speaking on addressing IPV and the perinatal mental health and perinatal mental health in South Africa, South African antenatal care. So addressing IPV and perinatal mental health in South African antenatal care. Thank you very much, and you're welcome, Dr. Hatcher.
Thank you, Burua. I think you can hear me okay and see my slide?
Yes, it's okay. Yeah. It's great.
Thank you. Well, that first presentation, thank you, Diandra. It really sets the tone for maybe adding a little bit more research to this important intersection of violence, mental health, and in the time of pregnancy and postpartum. We do work in South Africa in urban Johannesburg, where prevalence of IPV in pregnancy is roughly 1 in 4. And that's consistently high in many settings. And because we've been focused on the health sector, we have been seeing pregnancy and postpartum as windows of opportunity to engage women in care for their own safety and well-being, but potentially also for intergenerational benefits if they carry their infant to term. And so we ran a trial a number of years ago. It's not actually included in Diandra's systematic review because it's unfortunately caught up in some publication delays. But hopefully will add a bit more richness and complement the finding that Diandra highlighted. It was in 4 clinics in Johannesburg, and we implemented, similar to the studies Diandra cited, we implemented a counseling intervention that was comprised of comprehensive screening, empathetic listening, psychoeducation, and then some skills around safety planning. We also had a trained nurse do onward referrals to interested patients. Of the 423 women in the trial, we were able to follow up 86% to postpartum and learned that this intervention, which we called safe and sound, was effective in reducing new exposure to violence by 48%. And there were some promising results, both in terms of different types of violence and moderate effects on reducing physical violence, and actually even larger effects on reducing sexual violence. We also saw promising outcomes for recovery from depression and an increase in safety behaviors. We did not see effects on community resource use or self-efficacy. So in a perfect world, we would have an effective trial, and then that would be taken out into routine care. But of course, we all know things don't happen in a linear manner. And so we've really been thinking about the trial as sort of like the promising fruit, or the promising like beautiful flowers that happen if all goes well. But of course, there's a lot more in the root system that needs to occur to take these effective interventions into routine care. And so we've been thinking about the kind of factors that can inhibit or enable promising interventions to be taken into routine care. So I'll just highlight a couple for you. The way we're assessing this is through a pilot feasibility trial, which takes a small number of women through the intervention and compares them to standard of care. But we're also doing qualitative research to understand how the routine healthcare setting, again, could be kind of like the root system of this work going forward. So we were successful in hosting in-service trainings of routine health workers at 2 clinics, and found that the clinic managers were quite supportive. We were able to map out the flow that this kind of intervention would need to be effective in real-world settings. We learned health workers do want these skills, and that the training itself was supportive of offering skills around IPV identification and management. We were happy to find that referrals do exist and we were able to tailor these to the needs of each clinic. But there were some real negatives, and these will resonate with many of you. There was no incentive structure for the health workers we trained to actually take this on board, and the long queues of patients, especially in antenatal care and postpartum, made it very hard for health workers to actually take it up. They were also really weird and to be expected complexities of hierarchy. So even though we trained a lot of different cadres of workers, those who were at the lower rungs, like community health workers, were sort of deemed not able to take on this work by their sort of more senior colleagues. And so there's a lot of these interclinical hierarchies that we need to deal with a little bit better. Also, the clinic managers were fine with us doing this, but they weren't really champions of the work. And that was a real downside to getting this into routine care. Like most settings, our health workers themselves are exposed to high levels of violence. And so that highlighted for us the need for ongoing clinical supervision. But it also meant that the health workers did not want to take up that clinical supervision space. It was kind of hard for them to really dive into these details in a context where violence was very normative. So our team, with many others, has made headway in making the South African legislation take up the health sector as an important actor for IPV. But for right now, that only sits on paper and it hasn't been implemented into real clinics. So we're trying to improve the policy setting so that this could begin to inform routine care. But again, that's a very long path. So in conclusion, the outer setting, inner setting, and some of these factors around bridging and innovation are real complexities for taking something that showed efficacy in a trial into real world services. And I think one of the things we're considering is that the IPV field has gotten a little bit, understandably, focused in the trial moment, and that perhaps we also need to really be embedding these real life implementation issues. Thank you.
Thank you so much, Abby. Again, I started my timing a bit late, but I think you spoke about 7 minutes. That's brilliant. I've seen Q&A, something has popped up. Rebecca says, any ideas on how to improve buy-in from workers and managers at the clinics in future? Which incentives might work? I guess $1-million question, but what are your thoughts?
Well, a great question. I guess I think that we were a little bit overly optimistic. Like typical, we said, oh, this is such a promising model. Surely the managers and the sort of Department of Health and the health workers, they're all going to be on board. And what we found was health workers were actually on board because they see this with their clinic every day, but that the managers need something more, perhaps recognition of their role as a champion, and that Department of Health needs consistent feedback loops. And so I'm very happy to report we just had a meeting today with Department of Health. And I think that what we need to be doing is making that a regular feedback loop, instead of sort of like doing all of our work at the clinic without those sort of management champions.
Thank you so much, Abby.
Yes, thank you. It's a very different context, but in the UK National Health Service, we have something called sequins, where to incentivize clinicians to do something like assess for the risk of deep vein thrombosis or something, they have to sort of create a financial incentive to the service, which then creates top-down pressure on the managers to encourage the clinicians to do that particular task. And I don't know if that, yes, Abby's written sequins like with S. Yeah, it's pronounced that way, but it's C-Q-U-I-N-S. I think it's clinical quality indicator, something like that. And it's probably a very specific UK contextually relevant way of doing that, but I guess it's the same principle that if you prioritize it for the manager's metrics, they will then prioritize it for the clinicians that they are supervising.
Brilliant. And I like this idea of like, I feel you need the bottom up and the top down at the same time. So I think we're going to need to like borrow strength from other fields that are already thinking that way, like global mental health, like you're saying in the UK with some other care. Thank you. Bura, I don't know if we've got time, but you could text your question and I'll type back.
All right. Just a quick one. I just wanted to know your thoughts on continuity of carer, because in Ghana, the nurses are not the same. You don't see the same nurse every time you go to the antenatal clinic, and that makes it very difficult for the patients to bond and to talk about some of these things. So I just wanted to know your thoughts on that.
Such a good point. We were hoping to do even like 3 sessions antenatally, and it's just not possible. So part of what we're addressing with continuity of care is just having it be this one session. That's what felt efficacious in the main trial, and that's honestly what's realistic. It doesn't answer your question. It just sort of thinks about how we're working around that tricky dynamic in these busy clinics.
All right, thank you. Thank you so much.
Sorry, Bura, just unmute yourself.
Apologies, I keep doing that, forgetting to unmute myself. Okay, thank you, Dr. Hatcher, for that very insightful presentation. We are going to have our next speaker right away, and she is in the person of Dr. Diksha Sapkota from Griffiths University, Australia, and she's going to be talking about a pilot antenatal intervention for the mental health of women experiencing domestic and family violence in Nepal. You're welcome, Dr. Sapkota.
Thank you so much. Hello, everyone. I'll quickly share my screen first, and just let me know if this, if you can view my slide. Is it good?
Yes.
Thank you. Yeah. Thank you, everyone. Once again, welcome you all, and I feel pleased to share this platform with so many people with whom I have referenced in my work and whom work I have read several times. So it's a great opportunity to meet people like Hatcher, Karen, and everyone whose work has been cited several times in my study. So it's so hard to accommodate everything in this 10 minutes. So what I have done is that I will quickly go through, go through my PhD project, what I did, what I found, and what were the future directions. So it's a very brief recap of my PhD project, which actually involved 3 phases, where we design the intervention based on Dex review and expert consultation. And as Diandra has already mentioned, that the most interventions were focused on screening, providing some sort of education and counseling, and doing some referrals. So based on that kind of recommendations, we have developed our intervention. So our intervention included 3 key components. The first one was the information booklet, where we included scenarios, and the scenarios were mainly related to mental health symptoms as a result of violence. So instead of addressing domestic and family violence, the intervention was actually for improving problem-solving skill, and managing stress, and improving their social support. And we did include a safety behavior checklist recommended by so as to educate women on what are the safety behavior things and how they can plan for if such kind of situation arise in future. So that was the thing included in the information booklet, and we use that information booklet as a guide for counseling. So depending on what mothers want or what women want to be counseled about, we like it was like a guided counseling based on the scenarios on included in that information booklet. And we also provided telephone support where contact details of the counselor was provided to women, and women were asked to call at any time during that study period if they feel that they need some counseling or some sort of help to manage their situation. That can be any mental health situation or getting or coping against domestic and family violence. So that was very brief about the intervention. And we did a pilot trial. We did pilot randomized trial to evaluate the efficacy of the intervention. We did a 2-arm randomized trial with a nested qualitative study. So no doubt this research has contributed to this under-researched area, because there was actually no such antenatal-based intervention at that time, which were actually targeted for victims of violence. And it shows that such kind of intervention, it was feasible to implement, and it was giving some positive impact on mental health, help-seeking behaviors, and quality of life of women who have experienced violence in their life, in their life. And from qualitative interviews, we found that most participants perceived the intervention as effective and useful, but they reported several barriers in its implementation and uptake, particularly in regards to staff allocation, resources that is required to ensure its sustainability in future. And even they provided some recommendations on the structure and the content of the program, and so which I will talk in further slide. So all these findings are like quantitative findings and qualitative findings are published in 2 separate papers, and I'm happy to share the link of those paper later. So as an early career researcher, I would like to share what are the challenges that I experienced in doing this kind of field work. Like I'm based in Australia, where I did my PhD, and my field work was in Nepal. So that also caused some challenges in implementing the intervention. We actually selected a hospital, a tertiary hospital, where based on the high caseload of pregnant women. But later we found that most women were coming either very early in pregnancy or late in pregnancy, which make them ineligible for the intervention, because we wanted them to be from 12 to 32 weeks for the follow-up period to allow adequate follow-up afterwards. So that makes them ineligible. And when we look for some possible reason, we found that the hospital where the intervention was implemented, actually it has a Safe Mother initiative, which is a government scheme to provide financial incentive to pregnant women who complete their 4 antenatal visit and delivered at the hospital. But at that time, it was taken out from that initiative, was no more available in that hospital because of the high caseload. So women were coming only to the hospital just for confirmation of pregnancy, or when they need some specialist attention, or when they have to do some radiological investigation. So that somehow affected our recruitment, and we had to allocate a longer time for recruitment. And we have faced some issues with follow-up because of that thing, because women were not getting incentive. They were now visiting the grassroots level facilities such as health center or health post, which were providing them with those incentives. So we were not able to conduct face-to-face interviews with women, and we had to do telephone interviews with women. And another challenge was that because this study was self-funded and it does not have any external funding except the PhD research fund, which is very limited. So we weren't able to recruit new staff just specific for this project. So we asked the antenatal staff to do some sort of preliminary screening based on demographic characters, and after those who were found eligible, they were screened to the research nurse for domestic and family violence screening. So actually it was planned like that, but staff were losing interest, and like they were not motivated because of the additional workload or the like this, and they were not denying that they won't do, but they were just trying to avoid doing that thing. So we have to ask for some other volunteer to do that work. She was actually a friend who was a psychiatric nurse at that hospital. So all those kind of adjustments need to be done. And another challenge was the timing of intervention implementation. So because we thought that pregnancy was an opportune time to intervene, and because many women will come to the antenatal clinic anyway. So no doubt many women come to the antenatal clinic, but they were already occupied with so much things to do during that antenatal visit, especially in that overcrowded hospital. So many women were reluctant to participate in the intervention, and even they said that it's not during their pregnancy, they want to keep that violence history aside, and they just want to focus on pregnancy care and postpartum care and immunization. So we found a bit challenge to motivate participants to get involved in the intervention. And definitely we did have funding constraint, and we were not able to scale up that intervention to other settings. But this study definitely provided some key recommendation for future research and practice. And because we found that many women were accessing such antenatal care in grassroots level health facilities, we recommend to scale up similar kind of interventions in wider healthcare facilities. And it was not the husband who was the perpetrator, it was mother-in-law as well. So, and even in qualitative interviews, women were asking to have some multi-perpetrator intervention, and they want to be involved in the intervention. So co-creating intervention targeting multi-perpetrators would be a new area to investigate further. And in our quantitative analysis, we could see that the improvements in outcome measures decline over time. And participant mentioned that a single intervention might not be useful in having that long-lasting effect, and they want multi-session intervention. So adopting a longitudinal approach would be beneficial to see the impact of intervention over time. And definitely integrating domestic and family violence screening into antenatal care, or either prevention to mother-child transmission counseling package. So creating a holistic package and integrating domestic and family violence screening as one component of the package would be helpful. Yeah, so that is all about my PhD project, and I'll just quickly talk about what I'm doing currently.
I'm so sorry, Diksha, you've had 10 minutes, so I probably have to stop you. I'm really sorry, it's very cruel.
No, that's
but really lovely to hear the overview of your work. And I think if people would like to hear the next stage, perhaps you can post the links to the papers in the chat. Does anyone have a very burning question? Otherwise, we might go to our next lightning talk.
Can I ask a question? Yeah, great work, Diksha. I just had a quick question around the staff losing motivation to deliver the intervention. I think that's something we've seen too in some of our work in the US. I was curious, are you planning to do any interviews with the staff subsequently to learn what might enhance their motivation to continue to deliver the intervention?
Sorry, your voice is broken, so I couldn't get what you were saying. Maybe some network issues.
I was just asking in follow-up to this concern that staff was losing interest and motivation in delivering the intervention. If you're planning on doing any subsequent work with the staff to understand what could enhance their motivation over time.
Yeah, great question. And actually, I had some informal chat with the staff to see what were the barriers. And most of them said about the financial incentive. So they said that if they were provided with some financial incentive, then they would do that. And another is that they want some solid instruction from the higher authority, where they say that is your work and you wouldn't be provided with other work, So they just want to be allocated that work specifically, and they want reduction in their other regular work so that they can balance that thing in their regular work schedule without overworking. So those two things emerged, but yeah, maybe it would be good to explore what would motivate them further. Yeah.
Thank you.
All right, thank you very much, Diksha. Very insightful work. Thanks for sharing your work with us. We are very, very grateful. Our next speaker will be Dr. Sharli Paphitis. I hope I got the pronunciation right. Forgive me if I didn't. From King's College London. She would be talking on imperialist review.
I can see your screen,
So improving the
Sharli.
mental issues. Welcome, Sharli.
Okay, hi everyone. So I am Sharli Paphitis, and I'm a research fellow in the section of women's mental health at King's College London. And I'm also the co-lead of the Violence, Abuse and Mental Health Network. The review that I'm going to be talking about today was done as part of a large global consortium in which we were developing a package of care to improve the mental health of survivors of violence. And I conducted this review quite recently. So yeah, let me tell you a little bit about it. I can't tell you everything because it was quite extensive. So let's try lightning through it. So just very briefly to highlight that a realist review examines how and why interventions may work in particular contexts or with particular populations. And so from a realist perspective, causation that happens within an intervention is actually grounded inside of its mechanisms of action. And the mechanism of action in an intervention comprises the resources that are provided through the intervention, but also, very importantly, the participant reasoning or responses to those resources based on their context. And so when you synthesize evidence through a realist perspective, you produce what are known as context mechanism output statements. And these describe why and how components of different programs actually work. So these CMO statements become units of comparison that we can use to evaluate inconsistencies or to develop program theories. So realist syntheses or realist reviews consider families of mechanisms in trying to answer these questions of what works, rather than families of interventions, as we might often see being the case in systematic reviews or in meta-analyses. And so you can see how that would be incredibly useful if you were trying to develop a package of care, to really understand what are the mechanisms of action that would lead to change. So that's roughly why we conducted the review in this way, using that realist method. And that's a very broad brushstrokes approach to how it works. So in our realist review, we wanted to understand the mechanisms of action underlying psychosocial interventions that improve the mental health of survivors of intimate partner violence. And because of the huge evidence base in this area, we included only reviews in our realist review, and we had 60 reviews to include in this review. And so from the synthesis involved in looking at those reviews, we developed 272 of those CMO statements that I just mentioned, and we refined those down into a final 73 CMO statements that's presented in our final model. Very briefly, this enormous model that I'm sure is very hard to see on the screen here is the model that we produced. And just to highlight, what you can see is the movement down the left-hand side of the screen of the context, the mechanisms, and the outcomes that we produced, looking at all of these 60 reviews of the interventions in this space. Now, I don't have time to go through all of this model. Obviously, that would be impossible. In fact, the full review ended up being 70 pages, which had to be cut down. And the full paper is published in +1, so you can go and have a look at it there if you are interested. What I want to highlight from this model, and I've pulled out here, is the families of mechanisms. And those families of mechanisms that we pulled out were broadly split up into 2 sections, those that detail the design and the delivery of the interventions, and those that were detailing the intervention component elements. And so the model is grounded in the design and delivery mechanisms, and these increase the feasibility, acceptability, and effectiveness of the intervention components. And then in the intervention component side, 6 families of mechanisms emerged, and taken together, these families of mechanisms provide a very coherent and comprehensive model describing how IPV interventions can help survivors move towards recovery and improved mental health. Now, I don't have time in this very lightning talk to go through what each of these mechanisms is all about. But if you are interested in how these mechanisms work, how they might work together with each other, you can go and read about each of the mechanisms and which interventions fed into the development of those mechanisms in the broader paper. But you can see that access to physical resources and services, enhanced safety, control and support, increased knowledge, alterations to affective states and cognitions, increased skills to improve self-management, and improved family and social relations were those 6 families of mechanisms, all of which have further mechanisms inside of those families. So because I don't really have time to talk through all the families of mechanisms, because that would just take far too long, what I thought I would talk about were some of the key lessons that we uncovered through the review, things that we could draw out that we came to conclude as a result of putting together that model and drawing out all of those mechanisms. So the first one I'll talk about is self-efficacy, agency, and empowerment. So what we found was that factors supporting survivors' adaptive coping strategies include self-efficacy, agency, and empowerment. And these strategies are interrelated and all play a part in shaping survivors' beliefs and attitudes, or their internal reasoning about their ability to effectively plan and manage changes to their situations. And so this is a really important grouping of mechanisms for improving the mental health of survivors of violence. Next one I want to talk about is social connections. So multiple mechanisms across the range of interventions have at their core the development and strengthening of social connections. And these include the importance of building a therapeutic alliance, but also fostering perceived or actual social support. And very importantly, I think, the effectiveness of group and mother and child interventions. And the next one I want to talk about is safety, practical and psychosocial concerns. So what came out very strongly in this review was that fully supporting the recovery of women survivors of IPV requires interventions to address the full range of safety, practical and psychosocial concerns that women present with. Safety and material and psychological stabilization really need to be addressed prior to the provision of specialized therapeutic care. And this came out very strongly in the review. And then moving on to thinking about design and delivery, what we found was that really careful consideration needs to be given to intervention design and delivery, regardless of the specific psychological therapy that's being selected for use in an intervention. So as well as increasing the likelihood of intervention acceptability, uptake, and retention, the design and delivery of intervention themselves actually have a significant bearing on the mental health outcomes. And that came out really strongly as well. And then thinking just that interventions that are culturally relevant, individually adapted, tailored to IPV, and trauma-informed were really likely to yield the best results. That was one of the main findings of this review. And then finally, something we tried to emphasize very strongly in this review was that comprehensive IPV interventions that incorporate multiple mechanisms, so in other words, multi-layered interventions, are actually the most effective. So interventions should aim to incorporate as many of the mechanisms in that model as are feasible. Multi-layered interventions that operate through multiple mechanisms and address the variety of challenges faced by survivors in a really integrated way can lead to increased access to resources, reduced violence, and ultimately improved mental health. But a failure to follow that multi-layered approach can prevent some of the most vulnerable women, particularly those with complex mental health needs, from accessing relevant services. Now, obviously, resource constraints could limit the possibility of delivering multi-layered interventions, but those might be addressed through developing partnerships and referral pathways between services. I'm not actually sure on my time, but I thought I'd also just point out 3 of the biggest research gaps that we found or that were suggested in the review. So firstly, women in abusive relationships will often not want to leave their partners and may seek to improve the dynamics within their current relationships. And couples-based educational activities and therapeutic activities warrant a lot more further attention and consideration, including when and how they can be provided safely. There just wasn't enough evidence there. And secondly, harmful stereotypes about certain groups of survivors do create barriers to culturally sensitive interventions, and they limit empathetic concern for survivors, even among mental health professionals, and contribute to a lack of advocacy. So future studies really need to aim to explore these stereotypes and the impact of provider and institutional prejudice on the provision of service for survivors of IPV. And then just lastly, to say a really important thing that came out for us was that interventions very rarely focus on positive mental health versus being symptom-free or on helping survivors to really thrive. And interventions that focus on addressing guilt or increasing self-care and hope, reframing inaccurate cognitions, and changing self-concept all look like they could play an important part in assisting survivors to develop skills for long-term flourishing and support them in their journey for regaining a sense of meaning in life. But resources are needed to develop and test specific interventions and approaches along these lines that really focus on thriving beyond IPV. That is the findings of that review in a nutshell. And thank you for listening.
That was perfect timing, Sharli, exactly 10 minutes. I've got a little comment. Ameeta says, I really like changing the narrative to focus on healing and thriving. Yes, I think that seems to be very neglected in the literature. Does anyone have a burning question? Just conscious of time, I don't want us to be too late to come to Professor Devries' talk at 2. Can I just ask you, Sharli, your review was, I think, completely global in the source of your references, but do you think the findings, I imagine the literature is heavily skewed to high-income country settings, but do you think they have relevance to global settings?
Yeah, it was actually very global, and because we included reviews, there was quite a lot of low middle income country studies that had been included into the reviews, but obviously it does tend to skew towards high income countries, of course. That being said, there are some areas where the evidence base is slightly better in low middle income countries. So things around finance interventions are actually slightly better in the lower middle income countries. At least that's what we were seeing when we were doing this review. But yeah, I think the idea behind making the model was that it's drawing out mechanisms that are context specific. So the CMO statement helps to bridge context and mechanisms so that what's being put forward as mechanisms can be adapted to specific contexts. That's the idea. I hope that answers your question, Roxanne.
Yes, absolutely. Thank you. So again, apologies for the short time that everyone's been given, but I think Baru will take us on to our next lightning talk.
Yes, exactly. And the next lightning talk is from Dr. Yvonne Otchere, CEO of Psyccare Ghana, and she will be talking on approaches to addressing violence, abuse, and mental health in Ghana. You're welcome, Dr. Otchere.
Thank you for having me. Hello, everyone. So I'll share my slides in a minute. Right. So I'm very excited to be here. My topic is Everyone at the Table, Approaches to Violence, Abuse, and Mental Health in Ghana. And I'm very excited about this. Well, Ghana seems to be a very traditional society with so much concerns on mental health now. I mean, now we've had an evolution on mental health care. And so we've realized that a much more concerted approach to mental health care and delivery has been of primary concern in recent times. I have done a lot of work on violence among diverse groups, and also concentrating on very marginalized groups. From 2014, I've looked at data from vulnerable groups like MSM, and also, IPV, also looking at IPVs as well. So it's quite interesting looking at the dynamics and also focusing more carefully on all the factors that are influencing gender-based violence in Ghana. The statistics are quite interesting because about 94% of children between the ages of 1 to 14 have about 94% of them have experienced some forms of violence. And we also know that over 48% of women and girls have been impacted by violence and diverse forms of abuse as well. The approach in time past was literally that of a traditional and medical model. Recently, we are seeing an integration of much more of a biopsychosocial approach, where we are seeing that there's much more inclusion of, a mental health assessment of perpetrators in the legal, especially being required of the legal and judicial systems. We've seen much more a reformation of social constructs around abuse and GBVs as well. And we've also seen a much more integration of social interventions that are directed towards social norms, and then technology as well. Very interesting. So when I talk about biopsychosocial ST, then I'm also focusing on spirituality and technology as well. The statistics are quite interesting because we are also finding that for the longest time, about 38.7% of ever married women have experienced some form of abuse. And the statistics keep changing, increasing in recent times when you have a review of the documented literature. It's quite interesting when we look at the diverse stakeholder approach to gender-based violence in Ghana. And I think now than ever, there's a much more integrative approach. We've seen a lot more work around we see a lot more work from the media space, for example, in terms of reportage. We've seen a lot of education on, keywording, even in linguistic communication of GBVs in Ghana. We've seen a lot more training and advocacy that have gone on over the period of time. We've also seen a lot more of, and I quickly want to add that these stakeholder approach significant gaps have also been identified with these different approaches. So I'll talk about it as I go along. But as much as we say that the media has been very much involved in helping draw awareness and creating a lot of advocacy platforms, we've also seen on the other side a lot of sensationalism around reports on abuse and especially abusive victims of abuse. And we've also, that has also kind of steered stigmatization in increasing measures. We've seen a lot of advocacy work from civil society organizations. We have the ACT Foundation, we have my organization, Psyccare, and we've also done a lot of research work and community-based intervention projects, just focusing on support systems. And I really identify with Dr. Sharli's global review and the narrative that very culturally sensitive interventions are very much key in addressing issues pertaining to GBV, especially in Ghana. We've realized that is also of primary concern as well. We've seen organizations like FIDA, which is also specifically a women's mental health and professional advocacy projects, doing more work on sensitization and also targeting the peri-urban and the very local communities where there's a lot more economic deprivation and there are struggles along care, financial care and other basic elements that reinforce GBVs in our local communities. So we've had a lot more of legislative regulations in recent times. We've had institutions that are reinforcing a very proactive approach to GBV in Ghana. For instance, we have the Mental Health Authority reinforcing its laws in recent times, and we've seen a lot of advocacy work and a much more person-centered approach towards GBVs. And that has not come without challenges as well. For instance, some women we've worked with have reported of, partners who on the other side of the power imbalances and all, steering the process with money and, their power influence and other forms of influences that increases the disparity in terms of judicial care and legislative care as well. And obviously, when these women are found within the lower end of the economic spectrum, then they are actually found at a disadvantage in entirety. We've seen a lot more of domestic violence unit support systems decentralized all over the regions, and we've seen a lot more advocacy work around that. I think the problem in recent times has been a lot more stigma. This is a very communal society where everyone seems to know each other, and so based on some cultural norms, these women tend to shy away from addressing some of these abuses through a legal phase. And more often, sometimes, even when they choose that outlet, you have family members and other familial elements, intruding the legal system, and sometimes asking that these cases are kind of moved into the local home settings and addressed accordingly. Beyond that, sometimes we also have the ADR, the Alternative Dispute Resolution Centers, which have also helped to address reports on abuse and GBVs as well.
Yvonne, you've got just a minute left.
Yeah, so in terms of healthcare, we are seeing a lot of improvement. And I think from 2019, there's a very larger integration of professional healthcare systems into the mainstream healthcare. So now we have a lot more access to clinical psychologists, to social workers, and I think that that's also a very progressive aspect of this whole intervention. And I would say that from our side, for example, my advocacy group, we've advocated for a lot more culturally sensitive models, and that will help address GBV concerns, a lot more research work that are context-based and very understanding of the divergent factors and the reformative factors that are influencing the relationship as well. And for instance, we've advocated for the Whistleblower Act, which is very much recognized with corruption-based violence. So why not extend that to, abuse, GBV abuses as well? And then we've also created a lot more platforms using social media and other outlets to reach out to vulnerable groups, especially women as well. So thank you so much.
Thank you so much, Yvonne. That is 10 minutes. Does anyone want to ask a question? I was personally very interested in what you said right at the end about links between corruption and gender-based violence. Not something I've ever really thought about, but actually it sounds very relevant. I don't know if you want to say one word on that before we move to the next speaker.
Yeah, so we find that when it comes to different forms of abuses, there's a lot more attention on on corruption, a lot more attention, a lot more structured system to, kind of punish the perpetrators. So what we've advocated, through our research outcomes is that if you have laws that, kind of protect the victim, but allows them to report their acts in a way, and they get the kind of care and intervention that is needed, why not kind of extend that legislation to sexual and gender-based violence, for instance, and have these women protected. And in that manner, there's a lot more on stigma and, self-stigma, social stigma, that's very much controlled in many ways as well.
Thank you so much. I'm conscious of time. Barua, can you introduce our next speaker, please?
Yeah, thank you very much, Dr. Otchere. A lot of the points you made I can identify with, and that's very insightful. Our next speaker is Dr. Reshmi Mukherji from the University College London. She will be speaking on violence as a form of enacted stigma and its impact on mental health among women living with HIV in India. You're very welcome, Dr. Mukherji.
Thank you for that. I will try to share my screen. Is that okay for everyone?
Yes.
Okay, thank you. Thank you for having me today and for giving me the opportunity to present the slides of my PhD research. So Dr. Kalokhe gave a really great talk on domestic violence in India, and hopefully I can take that a bit further here by showing how domestic violence is related to HIV stigma for Indian women living with HIV. So a bit of background. The first case of HIV in India was reported among female sex workers in Chennai in 1986. The epidemic peaked in India in 1999 with over 3 million cases and has declined ever since. Compared to other countries such as those in sub-Saharan Africa, prevalence remains low at just 0.21%. But due to the sheer size of the Indian population, this still means that India is home to the second largest population of people living with HIV in the world, with about 2.4 million people living with HIV in India in 2021. Just want to touch on the infographic on the right about India's progress on the UN's 1990 targets, which was set to be achieved by 2020. This is based on 2018 data, where we see 79% of people living with HIV were aware of their status, of whom 71% were on antiretroviral therapy, but there was no data available on how many of these people were virally suppressed. While no country was able to achieve the target, India's progress was below the levels achieved globally. According to an article in The Lancet, HIV-related stigma was a major barrier to achieving India's 1990 targets. The Indian epidemic is mainly driven by heterosexual transmission among high-risk groups such as female sex workers, men who have sex with men, injection drug users, transgender women and their partners, and bridge populations such as migrants. Female sex workers pass on the infection to their clients, who then pass it on to their spouses and partners. Similarly, men who have sex with men and injection drug users pass on the infections to their partners, and that is where the epidemic is slowly transitioning. The world has increasingly witnessed a feminization of the epidemic, and India is no different, with 44% of all new infections reported among women about 15 years in 2020. One unique aspect of the epidemic among the general population of Indian women is that HIV is reported almost exclusively among married monogamous women, with 90% of women reporting sex with their husbands as their only risk behavior. Now, domestic violence in India has been cited as a significant mediator of HIV risk for women in India and South Asia, with high levels of domestic violence being consistently reported from the region. I use the term domestic violence to include either intimate partner violence or violence from in-laws or both, given the Indian cultural context, as Dr. Kalokhe explained in her talk so well. India has a rich sociocultural history of violence against women, and when the perpetrator is an intimate partner, then the violence is often sanctioned by society and accepted by women. Domestic violence has been identified as one of the most important structural issues for HIV prevention in India. So how is domestic violence linked to HIV? There is in fact a bidirectional link between HIV and domestic violence, with domestic violence increasing the risk of acquiring HIV and HIV increasing the risk of experiencing domestic violence. A 2008 study showed that domestic violence is a significant mediator of HIV risk for Indian women. Specifically, intimate partner violence increased HIV risk directly by taking away a woman's agency to negotiate safe sex, and indirectly, as abusive men tend to engage in more high-risk behaviors and so are more likely to have HIV and pass it on to their partners. On the other hand, women living with HIV tend to experience greater domestic violence, as seen in several studies from both high and low income settings. However, a systematic review that I conducted showed that only a third of the studies attributed this violence to enacted HIV stigma, even though the outcomes described, such as verbal and physical abuse, abandonment, and so on, were the same. This brings me to my research questions, which are, is domestic violence a form of enacted HIV stigma for women living with HIV? And how does the stigma-related violence impact women's mental health? In order to answer these research questions, I conducted fieldwork in Kolkata, India, which is in the eastern part of the country and shares a border with Bangladesh and Nepal. The state also attracts a huge number of migrants from the neighboring states of Bihar and Jharkhand, which together makes West Bengal a hotbed of trafficking. West Bengal ranks 4th in the country for all new HIV infections and ranks the highest for domestic violence. These statistics make West Bengal a good setting for studying HIV stigma and domestic violence. My methods of data collection included in-depth interviews with both women living with HIV and key service providers. Women were recruited purposefully through an NGO which provides inpatient services and outreach support for people diagnosed with HIV in both urban and rural West Bengal. Key informants were recruited by utilizing both my professional and personal networks. These are two summary tables of participant characteristics. Of the women interviewed, the majority were from the general population with a median age of 35 years, were mostly either married or widowed. Most were seroconcordant and reported acquiring the infection from their husbands. Over 70% of the sample had experienced some form of violence in their lifetimes from a partner or in-law, which was much higher than the general population. A diverse set of key informants were interviewed to gain a broad perspective on HIV-related domestic violence. So this brings me to my findings. My first set of findings indicate that domestic violence is in fact a form of enacted stigma for women living with HIV. Several women reported violence commencing or increasing only after an HIV diagnosis. The worst violence was usually experienced in the initial period after diagnosis when stigma was high and reduced as the years went by, when possibly women had the ability to challenge the stigma and had reduced internalized stigma as time went by. And women with additional marginalized identities, such as widowhood or having daughters, suffered additional stigma, which resulted in worsened violence. In the next slide, I will share a story of a woman to show you how multiple stigmas intersect at different time points in a woman's life, causing her to suffer from worsened violence. Mira was married off to a much older man when she was very young. She was already a mother of two by the time she turned 18. Her husband, who had been married before and had two children from his previous marriage, was often physically violent with her. She was beaten for many reasons, including giving birth to a girl. After a particularly violent episode, her mother-in-law and husband threw her out of the house with her daughter while keeping her son with them. She lived with her own mother and worked, but at some point her husband came back to her and returned to be begged to be taken back. She later found out that her son had died. Anyway, she started living with her husband again, and soon after giving birth to her second daughter 2 years later, her husband forced her to get pregnant again, at which time she was diagnosed with HIV and TB. Once the diagnosis happened, her husband immediately put the blame on her and disowned the unborn child. At this point, it was found out that the husband was in fact living with HIV and was already on ART. And once this was found out, this led to a huge escalation in violence. In addition to the physical violence, her husband forcefully stopped her taking medication. Her son was born but died 2 months later, which led to her husband leaving her again, saying that she was a demon who had devoured his sons. Soon after she heard that her husband, so after he left, soon after he died, then she went to see her in-laws with her daughters and asked if she could stay with them. Her mother-in-law said no, she did not need another HIV in the house. Better she go and prostitute herself, and when the girls grow up, they can join the profession too. If she had a son, the mother-in-law could have considered letting them stay. She was also denied her right to her husband's property. She then came home to her own mother's house, who refused to support her. She ended up begging on the street for food. In the end, she got so sick that the neighbors took her to a hospital, from which she was rescued by this NGO where she has been living with her daughters ever since. This story illustrates the heightened violence experienced by women living with HIV who also have multiple marginalized identities, such as widowhood, having girl children. This led to the development of this conceptual framework, which shows how multiple stigmas intersect to amplify stigma for women living with HIV, which manifests as worsened violence against women. I will now quickly describe my second set of findings, which show how stigma-related violence affects women's mental health. As expected, women's mental health deteriorated after women started experiencing stigma-related violence, as described by this 30-year-old woman. They tell me, I heard that you have this AIDS disease. It hurts to hear all that. I had the disease, but I was dealing with it on my own. I was working, I was fine. There were no worries. Now I cannot sleep at night. I don't have an appetite. A mental tension has entered into me. Then my heart just broke that I would live. What would I fight to live for? I used to be quite plump before. I used to work, but I didn't have to worry. But now as the days go by, it's like so much worry has entered my mind. What will happen is like my mind is not working. The way they treat me, they even beat me.
You have 1 minute left, Reshmi.
Yeah. However, a more interesting finding was that the poor mental health had a negative impact on women's physical health, primarily through 3 pathways. Women refused to take medication or be engaged in care. Women felt that chronic stress caused their CD4 counts to fall. And the physical effects of stress, such as reduced appetite, insomnia, general weakness, and body aches, made women feel very unwell. This led me to further refine my conceptual framework on stigma-related violence to show that this led to a poor health cascade of mental and physical health. I want to conclude with some recommendations for future research, where I think we should include studies with the partners and in-laws of women living with HIV to understand their reasons for perpetrating violence. In addition, future research could involve studies to test HIV stigma reduction interventions to see if this reduces domestic violence against women living with HIV. Also testing positive coping strategies, such as focusing on positive self-identities or challenging stigma from others to see how this leads to improved mental health among women, may be a promising avenue of future research. Thank you.
Thank you so much, Reshmi. And sorry to cut you short. I found the, especially the way that you've told us a personal story of a woman very moving, and that just the way these patriarchal norms just compound one on top of the other, extremely upsetting to hear, but very, very helpful to think about it in the body of one particular woman. Does anyone have a burning question before we come to our last lightning talk? Ameeta.
I'm sorry, I just had a quick question, Reshmi. I think that was absolutely wonderful work, and yet so sad on so many levels. And I was just wondering, as we think about stigma reduction, like, where do you begin? Like, clearly there must be an element of internalized stigma also. Like, how do you envision starting off thinking about interventions around stigma reduction?
So right now, what the ART centers do is they do counsel women when they're first diagnosed. Maybe, and they do have a component where they will bring in like the husbands or sometimes the in-laws, but I don't know how much this is actually being done to the extent that, but maybe making it like a point for husbands and in-laws to be counseled along with the woman as soon as they're diagnosed in a very intensive way. And also this conversation about U equal to U has not happened because no one talked about it in my in the whole of all the people that I interviewed. So I think that's a big step to reducing both enacted and internalized stigma, because if people don't think you're infectious, that was another reason why violence reduced over time. If they thought people were not infectious or they were healthy, people stopped perpetrating violence on them. So maybe that could be a promising sort of a segue to get into reducing stigma, both internalized and enacted.
Thank you.
Barua, would you like to introduce our final lightning talk?
Sure. Thank you very much, Reshmi, for that very insightful presentation. We are very grateful to you. Our final lightning talk will be from Dr. Noha Vera San Juan and Sophie Moniz from the University College London. They will be talking about creating a toolkit to assess the needs of sexual violence survivors in disaster and emergency settings. You're welcome. We're looking forward to
Hi, everyone. You can see my presentation, I hope. Let me know if you can't. Unfortunately, my colleague Nora can't make it today, so I'll be presenting on my own. But thank you very much for inviting us to speak, and it's a pleasure to be here and to have listened to all your very insightful research that you've done. So I'm going to present today on the process of collaborating to make a toolkit between academics and professionals on the ground. We're in the middle of co-creating a toolkit with MSF to assess experiences of violence and needs of violence survivors in humanitarian contexts. So the focus today won't be on content, as we're very much in the process of making this toolkit and it hasn't been rolled out, but more on the approach of the assessment and the process of collaboration. So first I'll provide a short background on REAL, which is us, we're the academic team, and MSF, the collaborating partners, before reflecting on the toolkit. REAL is short for Rapid Research, Evaluation and Appraisal Lab. And we're a research lab at UCL that specializes in rapid qualitative research. It's important to say that rapid does not mean rushing or less rigor, but rather taking approaches that makes the research efficient and agile. And when would you use rapid research? You use it because timeliness influences the utility of the research findings and evidence-based decision-making, as well as to respond to time-sensitive contexts. So for example, humanitarian emergencies or in hospital settings, among other contexts. Here are some key characteristics I won't go into in the sake of time, but the principles are being efficient, team-based, using iterative data analysis, and being participatory to facilitate the process. So our collaboration partners are MSF, Doctors Without Borders, who are a non-governmental organization who provide humanitarian aid in the form of medical assistance. They work in a variety of humanitarian emergency settings where REAL's rapid approach is appropriate to implement. And we've worked with them on a variety of projects, training them how to carry out rapid research and supporting them in projects on the field. So there's a drive in the organization to use more qualitative data collection methods to inform their programs and to evaluate them. And so they've identified a gap in assessing needs of violence survivors and mental health and psychosocial support needs, and they approached us to help them create this toolkit. So what is the toolkit and why is it being created? The objective is to create a toolkit to assess the experiences and the needs of violence survivors with an emphasis on sexual violence survivors and mental health and psychosocial support needs. The aim is to inform the creation of MSF services in these contexts, so to ensure that they're person-centered and appropriate when they create these services, and also to create an accessible and detailed step-by-step guide on how to conduct these assessments, because they've had different documents and tools to roll out assessments for sexual violence survivors and mental health and psychosocial support, but they're not accessible and easy to access. So that's our kind of role, is to advise on how to make this something that can be genuinely implemented. What does the process look like? So first I'll speak about the team, as this is a core aspect of the collaboration. Our role as REAL is to provide the instructions and the tools. So for someone reading it, understanding how to conduct the assessment, when it's appropriate, when it's not appropriate, how to use the tools, as well as providing the tools themselves, which includes the use of the REAL sheet. And this is a tool we have that facilitates data collection and analysis in parallel. And then MSF provides the MSF specific information. So terminologies they like to use and other values that their organization is guided by, as well as the realities of what can be rolled out in their organization and in the field. The team is multidisciplinary and it's a small team. There's our research team who provide the expertise in the research skills. And then there's the subject matter experts, one mental health advisor and a sexual violence advisor. So throughout the process, we've reflected on different factors coming up that are important to bear in mind. I'll share two that are related to collaboration. And one is, it's important that the process is iterative, meaning feeding back into the creation of the toolkit a lot and sort of taking it slowly to consider how to create it and not just having one kind of go at it. So it's important, especially because of the subject matter and ensuring you're not getting ahead of the game. So when you're working in humanitarian contexts and emergency settings, it can feel like you want to get it done and kind of it has to be done yesterday. But in order to have a truly beneficial and appropriate toolkit, the process is important and can't be rushed. So constant communication is necessary and voicing concerns or ideas. And then another one is having competing priorities might happen. It's beneficial to have multidisciplinary teams, but sometimes this means that different team members have different priorities. So it's important, again, to have this constant communication around what's realistic, what's appropriate, and what's feasible, and also constantly keeping in mind the end goal. Finally, apart from those considerations, there are a few themes that are useful to think about for future collaborations and making toolkits in violence and mental health settings. One is asking where, because considering the context the toolkit will be rolled out will impact what is relevant and appropriate to include in the toolkit. This toolkit will be a general toolkit that will be rolled out in various settings, but not just any setting. And at the moment, we're still in the process of refining it, but it'll be in protracted emergency settings, which are emergencies that kind of happen over a longer period of time and where people have been dependent on humanitarian assistance for a prolonged period of time. So there's already that kind of familiarity with the context and also with MSF. It's necessary also to define necessary conditions for rolling out the toolkit. It's great to have something that is accessible, but you can't just have it without conditions such as training data collectors and having referral systems, making sure that if someone discloses incidents of harm or threat of harm, that you have referral systems in place. And then also to have a multidisciplinary team. So having experts on MHPSS and sexual violence is very necessary to decide how to approach this and how to roll it out. And that brings me to the end of the presentation. I hope I didn't go too fast. I was wary of time. But we do love collaborating. So if anybody would like to reach out to us or look at our website, then please do feel free to, then drop us an email. Thank you. Stop there.
Thank you, Sophie. I don't want to jump in with my own question before anyone else has had the chance to ask. It just gave me a lot of thoughts about, my imagination is that the MSF largely works in settings of acute crisis, so perhaps people living in temporary accommodation, maybe camps, and so just the few papers I have read in humanitarian settings often identifying how hard it is to address relationship violence because people are focused on other priorities, you know, the hierarchy of needs, starting with their housing and their safety and health. So I guess MSF actually works in a wider set of contexts than just the acute crisis. Is that right?
Yes, they do work in, many of their work, I guess, is in kind of like long-term emergency contexts. So they're where they've been for a while in like conflict settings or like post-conflict settings or nutrition crises, but that happen over a long period of time. They do respond rapidly in some situations, but not in, this toolkit wouldn't be rolled out in those. It's more like where they've had kind of an established base. If that answers your question?
Yeah, so I guess in that case, there'll be a real mixture of people who are perhaps living in relationships with abusive partners in which there may be sexual violence, but also just the reality that sometimes people are assaulted by strangers in those settings too.
Yeah, definitely understanding all those dynamics.
Complexities.
Yeah,
absolutely. Well, thank you so much for bringing that additional perspective, which I think we haven't had represented enough in iVAM events so far. And thank you everyone for our fantastic lightning talks. I recognize that it was a real tough one to ask everyone to speak in 10 minutes, but I think it was a really valuable experience, and I'm definitely going to watch the YouTube back to catch up on some of the papers that I want to read up on. Baru, I'll hand over to you to introduce our final speaker and keynote.
Sure, Zan. Our final keynote will be from Professor Karen Devries. She's a professor of social epidemiology from the London School of Hygiene and Tropical Medicine, and she will be speaking on the links between violence against women, children, and mental health. We are very grateful to have you, Prof. Please go ahead.
Thank you very much, and thanks for inviting me. Always very flattering to be invited to give a talk. So yeah, really happy to be here. So as was mentioned, I'm a social epidemiologist, and I've spent my career at the London School. And so there I lead a group of researchers called the Child Protection Research Group. And I'm also a longstanding member of the Gender Violence and Health Center at the school. So my talk today, it's broadly about violence against women and mental health. And so what I'm going to, if that will go forward, how I'm going to structure my talk is I'm going to start by just telling you a little bit about me and my background and why I study violence. And then I'm going to take you essentially on what was my own journey through violence research. And so through that, we're going to look at some of the research on intimate partner violence prevalence. So the first global estimates, which came out of the London School and WHO. And then we'll also have a look at the latest prevalence estimates. I wanted to touch also on methodology, because I think this is an area of kind of ongoing interest of mine in terms of research. Because as I think we all know on this call, it's quite difficult to actually get good prevalence data on experiences of violence. And then we're going to look a little bit at the health effects of partner violence. So what does exposure to IPV do to women's bodies? And then flipping that around, thinking about what are the causes of partner violence and where mental health fits in, because there's quite a complex dynamic going on, I think. Then finally, I will finish off with a few reflections on where we go from here, really, and what are the big questions in our field. And I would love to hear from everybody else on your thoughts about the big things that we don't yet know about violence and mental health going forward. And whenever I talk about violence, I always put a bit of a trigger warning on my slides. So if anybody does need to drop off for a few minutes, so just to take care of yourself, feel very free. I won't take it personally. And if you need any further support as we go through this or after today in general, I'm sure if you reach out to the organizers or myself, we can help signpost you as well. Okay, so how did I come to study violence? So I feel like this is reaching back into like ancient prehistory at the moment, but I started this journey a very long time ago. I'm from Canada originally, on the very, very far west coast by that green star, actually from an island off the edge of the continent. And growing up there, I had a very lovely upbringing, and issues of violence weren't so much on the kind of radar of my day-to-day life. So I was lucky, I think, as a child growing up in this setting. I went off to university, I got off my island, went to the mainland, and I spent a few years in Vancouver where I did my first degree, which was about genetics and cell biology. Decided after that, I do not want to do lab work, so I've had enough of this. So I then kind of returned to a longstanding interest of mine, which was about, women's health, women's rights, and reproductive rights. And I got a job doing research and also being a research assistant to our provincial office of Aboriginal health in Canada. So started to engage a little bit with issues of health rights and violence. Then I decided, okay, I think I need to do more training, particularly more quantitative training, because I think this could really help in this field, push things forward. So I then applied to graduate school, and somehow, very surprising to me at the time, London School accepted me. So off I went and went to do my PhD in the UK. And during that time, it was then that violence kind of properly came onto my radar as a research issue. And so my PhD was actually about sexual health, so kind of different topic. And I worked with some partners that I had and some work contacts that I'd made in Canada to look at the sexual health of Aboriginal young people in Canada. And that was a mixed methods PhD. And so during that, I analyzed some survey data, and then I did a qualitative study where I was asking people all about their experiences of condom use. And you know, it's quite naive in retrospect, but what came back from those interviews were a lot of stories of coercion and force and sexual violence, and also a lot about historical trauma and structural violence, which really shaped the contexts in which these sexual health decisions were made and in which violence occurred for this group. So that was a real eye-opener for me personally, this violence that I thought, yeah, that's a thing, but it's quite rare. Actually, I realized in a very personal way through that research, and that actually this is really common, and this is a major public health issue that we're just not paying enough attention to. So I finished that research and graduated, participating in, it seems to be a universal graduation ritual where you wear a weird hat. So I did that at London School. And in 2007, I finished that PhD. And then I joined the Gender Violence and Health Centre, which was founded by Charlotte Watts at the London School. And from there, my interest really in violence was cemented, and I started to focus primarily on that area. So when I joined the gender violence group, I was working on a few different projects. So one, I put up on the far right-hand side, that is a map of Kampala. So during this time, I started a kind of a stream of quite applied research where I was doing randomized trials of violence prevention interventions. And I spent a couple of years actually sitting with a partner NGO in Kampala, evaluating some of their violence prevention work. I'm not going to talk so much about that today, but that's another kind of strand of my own interests. And the other major kind of strand of work I started doing was around looking at the burden of disease related to violence. And so I'm going to go through some of the findings from that body of work today. Okay, so as part of the burden of disease project, I think a few people have alluded to it in presentations, but if you're not familiar with it in public health, the concept of burden of disease is really important. And it links the concepts of prevalence, so how common something is, to the health effects of that thing. So how bad is it for you? And then it allows you to kind of combine the prevalence and health effects into a common metric for very different diseases and conditions. And then what you can do as a policymaker is kind of line those up side by side and say, okay, in my population, you know, violence causes a higher disease burden than maybe cancer or road traffic accidents or whatever it might be. So one of my early projects, which so Charlotte Watts and Claudia Garcia Moreno at WHO, they led the expert group who was responsible for producing these burden of disease estimates for violence. And violence against women was included for the first time. And I was kind of the person who was the doer of all of the stuff. So I was running around like a mad woman for quite a few years, actually, to do a lot of this work. But through that, we managed to produce what were shockingly the first global estimates of the prevalence of intimate partner violence against women. And I think everybody on the call is going to be familiar with this number, but this is the big number that came out of that that research. So this figure of 1 in 3 women have experienced physical and/or sexual violence in their lifetime. So very high prevalence. And I think now when I say that number, everyone, A, they know it, but B, I think it's just seeped into people's consciousness. It's no longer shocking. Whereas when we first produced this, we were met with general disbelief by how high this number was. Of course, that big global average masks a lot of regional variation. And I think we've heard a lot about that from different speakers today, and talking about the importance of different contexts in thinking about, what constitutes partner violence and the prevalence, and also how we prevent it. But we can see, even in these kind of early global estimates, there's a lot of regional variation. And I think, well, I find that interesting for 2 reasons. So one, it says to me that violence is not inevitable. There's something going on between these very different figures to cause that variation in prevalence. So violence is preventable because we can theoretically get all these figures in line. And there's something driving that regional variation. And I have to say, now 10 years on from when we first produced this, I don't think we're actually that much closer to understanding what is driving that regional variation. Okay, so another major finding that came out of that initial burden of disease work, and this one was led by my colleague Heidi. So in this paper, we looked at intimate partner homicides. And so Heidi did a lot of work writing to literally every country statistics office in the whole world to get their homicide data. And what she found there was that 1/3 of all women who were murdered by their intimate partner. And that's in contrast to men, where, if I'm recalling correctly, I think it was about 5% of male homicides were perpetrated by an intimate partner. So really stark difference. And that kind of set of findings about the prevalence and then also the homicide rates really caused, well, a lot of media attention, and I think really helped these kind of numbers to seep into public consciousness and to really galvanize a lot of interest in this issue. And I know for me, I had to go on TV to talk about the global prevalence numbers, which as an introverted person, it was not a comfortable experience. But again, speaks to the wide public interest in this issue. So that was all kind of early, well, 2010 to 2013. And now 10 years on, colleagues at WHO have done an update of those estimates on the global prevalence of physical and sexual partner violence. And I know we've already seen this today, so I won't say too much about it. I would say the good news with this, this updated picture is that there is so many more data available than there were in the first round. So in the first round, I think we had 81 countries. And then in this update, I want to say they had prevalence data from 120 countries, but to be honest, I need to check that. But a lot more data available to do the global estimates this time, which is great because people are now collecting it. But I guess the less good news is that the prevalence figures on average do look broadly similar to what they were before. So indicating that we still have quite a lot of work to do to really tackle this issue at a global level. I also wanted to just say briefly about the methodological aspects of this research. And I was so excited to hear about the efforts in India to develop like a contextually specific measure of IPV with acts that might be more relevant, because I think that is so important. And we have so much work to do in this field. to better measure what people's experiences of violence are. I think probably, again, everybody here has had some experience or has run into some challenges. I know we certainly had loads of challenges during COVID with data collection in various projects. And I think that's been, well, a challenge and an opportunity in terms of violence research. So because of COVID, in a lot of my projects, we had to make a switch to doing remote methods of data collection. And we had a chance to do a lot of quite careful thinking about those methods and when they were appropriate to use, and to develop kind of safety protocols around using them. But I'm encouraged actually by what we found. So it seems that a lot of participants in our studies, particularly young people and adult participants, really actually liked having data collected in this way. And then I found it much more convenient to speak to somebody on the phone or to fill out something online than, you know, having somebody try to schedule an in-person interview, which is how we usually collect data. So these methods, I would say, you know, they're not appropriate everywhere all the time, but I think there's a lot of opportunity in them. And I think, you know, for example, they're often cheaper. People can fill out surveys and things more often. You can send it to them at different time points. So I feel like it opens up avenues for new discoveries around the kind of the nature and timing and frequency of violence. Okay, so that's about methodology. So now I also just wanted to say a bit about the kind of causes and consequences of violence. So this slide is again from this body of work linked to the initial global burden of disease study, and looks at some of the health effects of intimate partner violence exposure. So what does it do to our bodies? And again, through that work, we synthesized for the first time. So we did a lot of systematic reviews. And I know several people on the call have also done systematic reviews. So yeah, they're a lot of work and solidarity. I think back always to my experience of this project whenever anybody presents a systematic review. But what we found through this series of systematic reviews of good quality longitudinal evidence where possible was that women exposed to partner violence were twice as likely to experience depression, almost twice as likely to have an alcohol use disorder, 16% more likely to have a low birth weight baby, were 1.5 times more likely to acquire a sexually transmitted infection. And of course, there's associated injuries and deaths with experience of partner violence. So there's solid evidence, or this is from 2013, there was a range of solid evidence about the health effects of partner violence. Although at that point, I would say, these are a few kind of key issues, but actually there's a whole universe of other health effects where the evidence and the data just weren't there to allow us to kind of quantify them in a robust way. So that's thinking about some of the consequences of violence, and mental health definitely features as a prominent consequence of experiencing violence, which makes a lot of sense intuitively. If we flip this around though and think about the other direction, so what are the risk factors and what causes violence? And this slide, probably a lot of you will recognize Lori Heisey's ecological framework. So she was the first person to apply the ecological model to violence in a now classic article. This is from 1998. So she summarized at the time factors at the individual level. So that's personal history, that would increase a woman's risk of violence. So that is witnessing violence or being abused yourself. There's also factors kind of a level out from there. So in the microsystem of the family, for example, lots of gender power dynamics and patriarchal norms can influence risk of violence. Then perhaps a little bit more broadly at the exosystem or the community level. And then also at the broader macro level. So these are sort of broader cultural or national norms and policies. And she identified a range of factors across all of these levels that would impact a woman's risk of violence. So this is from 1998, as I mentioned, and I think looking at it now, we can look and think, oh, perhaps there's a few more factors that we could list in here. One of the most important being poor mental health. So I think if you look now at different studies, it's pretty clear that this association also goes in the other direction. So having poor mental health is a risk factor for future experience of violence. This one, this is a forest plot from a meta-analysis where we actually took longitudinal studies and we looked at this association. So right on the top, that group of estimates is from studies where they looked at exposure to partner violence and then incident or depression that occurred after that. And you can see represented by that diamond, there's an increase in the odds. So if you're exposed to IPV, you've got twice the odds of having a depressive episode in future. But looking at that group of studies at the bottom, actually, there's also equal evidence saying that if you are depressed, you have twice the odds of having an incident in the future of intimate partner violence. So there's actually quite robust evidence for both of these directions. So violence and mental health can be a cause and consequence of each other. And I think, this relationship, it's, for me, obviously of central importance for public health because of the prevalence of violence and the prevalence of particularly common mental disorders. These affect huge sections of the population. But I think in terms of the relationship between these two things, I think there's quite complex things going on. And the more you try to look at it and trace back what's causing what, I think the more confusing it becomes. So what I think is probably going on is that there's somewhat of a cyclical relationship between experience of violence and poor mental health. And I think that it can start at any point, but often the roots of these are laid before we get to adulthood, before intimate partner violence is occurring. So for me, my own research has shifted focus a little bit away from looking at violence against women in adult women. And I'm now a little bit more focused on looking at violence a bit earlier. So over the life course, up to the adult age of development. And I think when we're thinking about the causes of violence against women, it's pretty well established that excuse me, that earlier experiences of violence, so violence in childhood, seem to be causally related to experience of violence in adulthood. And I think mental health is part of that chain of causation. But if we look at the prevalence also of violence against children, it is extremely high. So 1 billion children, and that's half the world's population of children, experience some form of violence every year. And I think we, although we have ideas about this, we're still kind of in the early days of really understanding how children's early experiences are embodied. And I put some quotes from Nancy Krieger from one of her papers, because I love how she talks about embodiment to really frame, I think, how we need to be thinking about these experiences of childhood violence and their impacts on our kind of later selves. So Nancy Krieger says that bodies tell stories about and cannot be studied divorced from the conditions of our existence, which to me is really important, because it's not only kind of centralizing the kind of embodiment and physical embodiment of these experiences that happen to you, but also the contexts in which they happen, which I think is super important for prevention. She also says that bodies tell stories that often, but not always, match people's stated accounts, which again, I think is extremely relevant to violence prevention, because a lot of times these acts that people experience that I think are violence, people might not necessarily agree with that. They might just think this is a normal behavior. But I think we have work to do to understand the kind of physical embodiment still of those experiences, even when you don't consider them to be violence. And she also says that bodies tell stories that people cannot or will not tell, either because they're unable, forbidden, or choose not to tell. Which again, in violence research, is this stigma and underreporting are such important kind of considerations in what we do. And I think understanding the embodiment of some of this trauma that people experience almost provides another form, or could provide another way for people to disclose, so that we can fully understand the health impacts of these. Okay, so this is basically what I wanted to say. And thanks again so much for inviting me. I think at this point we can probably stop and take questions. And I wanted to ask you guys questions about, the big remaining unknowns in this field, and what you think pressing research questions are for you. I put up a couple of reflections from me. But I'm very inspired by all of the work that you guys are doing. So I would love to hear from you on this front. Okay, let me stop there and pass back to our hosts.
Thank you so much, Karen. It was lovely to hear you speak. I have been writing some kind of sentence in my articles along the lines of violence and mental health are bidirectionally linked, and then referencing your two meta-analyses for a really long time. So it's lovely to rethink that as a cycle with your diagram. I've captured that for our Twitter account. I think it's a really interesting point to highlight. Abby has said the quote, I think she means the one about embodiment, is very compelling and poetically speaks to measurement conundrums, especially retrospective requests about childhood trauma. It also made me think about the field that I was researching before I got into the violence in global mental health field, which was functional neurological symptoms, which are one example of ways in which in certain people, not everybody, but a proportion of people, it's thought that traumatic histories lead to bodily symptoms and manifestations of distress, which are also common in children. Sorry about the child noises in the background for me. Does anyone want to respond to the big questions in the field on the slide? We're a small group now, so please just go ahead, raise your hand and I'll unmute you.
I was actually just wondering because it is kind of a small group, would anyone else want to turn their video on for just this last little portion? If it's comfortable for where you're sitting.
Hi, Abby.
I don't know if this is too off the topic, but when Karen, you were talking about working with Charlotte Watts and Claudia Garcia Moreno, I was, of course, thinking about our program, which is entirely female in speakers, and whether you think, having worked in this field a long time, have you found key male allies who share the level of concern of women in the field, or is our program quite representative of those who prioritize this issue?
This is an interesting question. And I also want Abby to chime in, I know, based on your intervention experience in South Africa. Yeah, I think we, on the panel and in the meeting, I think we are very representative of who I see interested in and working in this field. And I'm not sure if there's a bit of a disciplinary thing going on as well. So I think to me, we represent sort of public health. I feel like I tend to see more male names in criminology who do research on violence, but it's from it's a different discipline, different perspective. But yeah, I have to say, over the years, I have worked majority with women, exceptions being more on the kind of programmatic side of things and more men involved there. But how important is that? I don't know. Anyone else want to share reflections on that?
Buria, would you say the quote or the sort of idiom that you mentioned towards the beginning of the webinar? It was about, I think it was Buria who said about a woman holding in her heart.
The heart of the woman is the graveyard of her husband's sins. Yeah, and that was in research that had been conducted in an African setting. I don't remember the top of my head which country it was, but you know, when they came in and they were asked about if they had any experiences of domestic violence, well, most of them said no, because of the cultural restrictions, you know, and to be considered a good wife, you know, you did not have to kind of snitch on your husband. You needed to keep the family secrets, you know, promote a good front for your family. So a woman who was found, you know, talking indiscreetly about the things that were going on within her family was not considered a good wife. You are supposed to protect and to nurture and to keep everything within. And that was, those were the notions that made up a good wife in their context. So, yeah.
Because I sometimes think of that in our field as well, that thankfully it's not only women, but I think that we're often, as women, kind of like holding this issue that's a very human issue, and everyone is benefiting from the gains we make, and everyone is also suffering, you know, when we're unable to match that. But I do think there's almost this extra burden, or perhaps recognition as women, and it sometimes, and as sexual and gender minorities. And so I think that it sometimes falls onto these same shoulders, similar to how it might do in a household or in a community. I think our academic sphere has that similar dynamic at times.
Well said, Abby. Guys, can I just say, I think I've got time for maybe one more question and then I've got to drop off.
I think the your perhaps more recent focus on children is so interesting. We now have it in UK law. Oh, I see Reshmi has a question, so I'll let her ask. I'll just comment that in UK law now with the Domestic Abuse Act, children are now recognised as victims of domestic abuse. They're not just other people in the home who were there when domestic abuse was perpetrated against their parent. So that is an interesting progression in the UK. But Reshmi, go ahead. You're on mute, sorry.
Sorry. I just had a question about that really beautiful quote that shows the stigma of talking about domestic violence. How can we address that? How do we make women, how are we able to make women talk about it more or just share their stories? I think that's really difficult in settings such as India, where the stigma is so much. So there is so much underreporting because of that. So I was really interested in getting your insights on that.
Yeah, I hear you. And yeah, I mean, it's an ongoing issue that I don't know that I have an answer to that question. But I guess what I would say is that just in my experience, like doing the studies that I've been involved in, I feel like research actually is such a powerful tool to allow people to speak and disclose. And, you know, like so often when we go to do a survey, it is the first time that people have disclosed. And I definitely find that as well with children. And it's perhaps even more pronounced with children talking about their experiences relative to adult women. And they just are like so surprised that somebody is coming to actually listen and wants to know about these things. So I think that the transformative power of the research approach actually shouldn't be underestimated there. But yeah, in terms of generally more disclosure and more help seeking, I feel like this is a whole other area of research that I've not really touched on. But I guess I would say, and it struck me also listening to some of the earlier presentations about antenatal care. I mean, if me as a woman going to my provider, just thinking of the interactions I had in my antenatal care with these guys, you know, at my health check, which consisted of one question, "You fine?" Me being like, "Yes, I'm fine." Moving on now. But yeah, I think if you're going to disclose, you know, you've got to be convinced that the person's going to listen to you and that they're going to take some positive action. So just at a very basic level, the services aren't there and aren't appropriate. So I think we've got a lot of work to do around like provider training and so on, which links to broader cultural shifts, etc.
Karen, can I quickly add that I think with the upsurge of technology and the use of technology, especially from our part, we've seen a lot more women disclosing experiences on gender-based violence. And I think that it's also the anonymity and, you know, that form of exclusive protection that, you know, I mean, they gain from access to these devices. So I see a lot more mobile apps, you know, being circulated to these women to have them access care, you know, and even support groups and all that. And I see that that's helping women to tell their stories in a lot of ways.
Thanks, Yvonne. I think that's so interesting. And yeah, links to these sort of methodological points as well that are in my mind about like all of the opportunity with remote data collection. But as you say, it can afford people the opportunity to disclose in all kinds of ways that that maybe aren't there in a kind of face-to-face encounter. So yeah, really interesting. Guys, I'm afraid I have got to go, but thank you again so much for having me. It's really a pleasure to meet all of you and to hear about all this really cool research that's going on. It makes me happy to be in this field again. So yeah, definitely stay in touch, and good luck to everybody with their next steps. Yeah.
Thank you so much.
Thank you.